Hello everyone, welcome to Patho Excellence. In this episode 11 of Endometrial Pathology video series, today we are going to learn general considerations of endometrial carcinoma. In this video, we are going to discuss what are the different types of endometrial carcinoma, its morphological and molecular classification, FIGO staging system, some grossing tips, and what are the microscopic features to differentiate endometrial carcinoma. So let's begin the topic. So what is endometrial carcinoma? It is malignant proliferation of endometrial glands, most common invasive carcinoma of female genital tract. It presents as postmenopausal bleeding, and it has two distinct pathways. One is hyperplastic pathway and second is sporadic pathway. So hyperplastic pathway is most common, and it is arising from endometrial hyperplasia and related to estrogen exposure. And risk factors include early menarche, late menopause, nulliparity, infertility with anovulatory cycles, obesity, PCOD, hormone-producing tumors like granulosa cell tumor of the ovary, and some genetic alteration. Average age of presentation is 60 years, and histology is similar to normal endometrium, so it is called as endometrioid carcinoma. Second, less common is sporadic pathway, and it is arising in atrophic endometrium. Average age at presentation is 70 years. Precursor lesion is serous endometrial intraepithelial carcinoma, and it is associated with serous and some clear cell carcinomas. Other associations include diabetes, dysfunctional uterine bleeding, hypertension, infertility, some syndromes, and tamoxifen used for breast carcinoma. Increased risk for endometrioid, serous and carcinoma, carcinosarcoma associated with this tamoxifen use. Histologically, it is usually serous and characterized by papillary structures with psammoma body formation. And already we have discussed in our previous topic, 53 mutation is common. And tumor exhibits aggressive behavior. So this is the model of endometrial tumorigenesis. Tumor arises from the polyclonal normal cells, which is initiated by mutation in small areas, which there is increased growth potential under the mitogenic influence of this estrogen hormone. These precancerous clones develop and progress through mutation and selection, and eventually reaching a stage at which hormonal support is no longer required for survival. So here we can see excessive estrogen exposure, which is leading factor, and at the monoclonal malignant stage, there is no requirement of estrogen hormone presence. So malignant transformation of these three cancers occurs by accumulation of sufficient genetic damage to permit invasion of adjacent stromal tissue. Now let's look at classification and grading of endometrial carcinoma. There are two types. Type 1 is endometrioid type, and type 2 is non-endometrioid type. Here the grades 1 and 2, 3, it is based on architecture, increase in grade by 1 based on mass, nuclear, atypia. There is endometrial carcinoma type with secretory differentiation, ciliated differentiation, squamous and mucinous differentiation. FIGO grades for endometrial carcinoma includes grade 1, where less than 5 or equal to 5% of tumor show solid non-glandular growth and it is well differentiated. Grade 2, which is called moderately differentiated, where 6% to 50% of the tumor cells show solid non-glandular growth. And grade 3, which is poorly differentiated, where more than 50% of the tumor shows solid non-glandular growth. Now, type 2, which is high aggressive tumor, and grading is not required because by definition it is mostly grade 3 in type, and it includes serous carcinoma, clear cell carcinoma, and carcinosarcoma, which formerly known as malignant mixed Mullerian tumor. Another type is miscellaneous, including squamous cell carcinoma, mixed carcinomas, undifferentiated carcinoma, and rare types include transitional cell carcinoma. Recently, IHC coupled with molecular-based studies which integrated with this traditional morphology classification to stratify risk, to determine prognosis and guide treatment the hereditary non-polyposis colorectal carcinoma or Lynch syndrome. So if we see molecular classification, so it is TCGA genomic-based classification of endometrial carcinoma, where there are 4 groups. One is polymerase epsilon ultra mutated group, in which there is ultra high mutation burden, and 6% cases are having this mutation, and mostly they are high grade endometrioid carcinoma. Best prognosis despite high grade appearance and often lymphovascular invasion. Second group, which is microsatellite instability and or mismatch repair deficient, where there is loss of mismatch repair proteins, which is MLH1, MSH2, MSH6, and TMS2, and microspillate instability is there. So these are 25% cases, mostly endometrioid type and associated with Lynch syndrome or this hereditary non-polyposis colorectal carcinoma. Third group, where there is microspillate stability and low copy changes. So it is called non-specific molecular group, which is 40%, mostly low-grade endometrioid type, and associated mutation are P10, ARID1A, CTNNB1, and it is having good prognosis. Fourth group, which is P53 mutation, which is extensive chromosomal instability, and around 20% of cases are showing these changes, which is serous or high-grade endometrioid type and aggressive and having worse prognosis. So if we see algorithm, how we classify using this pole sequencing MMR IHC and P53 IHC. So if endometrial carcinoma is there and it is pole mutated, then it is called pole mutated group. Now pole wild type is there, then go for MMR IHC. If it is intact, then we have to go for P53 IHC. And P53 IHC, if it is normal, then it is non-specific molecular group. Abnormal P53 mutation, that means P53 abnormal group, mostly serous or high-grade endometrioid. And if MMR IHC lost, then it is included into MMR abnormal group. This is a recent 2023 FIGO staging system for endometrial carcinoma, including molecularly defined stages. So it is divided into 1A1, 1A2, 1A3, 1A mutation pole mutation, 1B, 1C, 2A, 2B, 2C, and mutation including P53, 3A1, 3A2, 3B1, and B2. So basically, first stage, 1A stage is associated with mostly endometrium, and less than 50% myometrium. 1B, which is more than 50% myometrium with no or focal lymphovascular invasion. 1C, it is limited to endometrium or endometrial type, but it is having aggressive histologic type. So non-aggressive, low grade, non-aggressive with myometrium, and 1C, it is aggressive, limited to endometrium. Now, stage 2A, which is, or 2B, which is non-aggressive invasion to cervical stroma. In N2B, it is non-aggressive with substantial lymphovascular invasion. 2C, which is aggressive type with myometrial infiltration. And this 3C group with mutation P53 abnormality is confined to uterine corpus with any myometrial infiltration with or without cervical invasion, regardless of lymphovascular invasion or histologic type. Now stage 3A1, spread to ovary or fallopian tube. A2, involvement of uterine subserosa or serosa. B1, where metastasis or direct spread to vagina or parametria. And stage 3B2, which is metastasis to pelvic peritoneum. Now, how patient presents? Mostly they are with abnormal uterine bleeding, mostly postmenopausal bleeding, clear vaginal discharge, and some symptoms like weight loss and anemia. Some patients are diagnosed after abnormal cervicovaginal cytology result in pap smear. Now, for the diagnosis, we require pelvic or transvaginal ultrasound, which is first line and non-invasive test. It detects endometrial thickening, polyps or mass lesion, and it is also helpful for further sampling of endometrium. Hysteroscopy, which is helpful for targeted biopsy or intact removal of polypoidal lesions, and endometrial sampling are mostly mainstay for the diagnosis of carcinoma, and there are two methods. One is endometrial biopsy and second is endometrial curettage or dilatation and curettage. Radiologically, in premenopausal women, any focal lesion like polyp, nodule, irregular thickening requires biopsy. In postmenopausal women, any endometrial thickening which is suspicious, previously the threshold was more than or equal to 10 mm, but current recommendations says that more than 5 mm or even more than 3 or equal to 3 mm may warrant sampling. These are the prognostic factors which include staging of the tumor, invasion including myometrium, cervical, serosal, adnexal or lymph node, type, histological type of the tumor, and grading of the tumor, vascular invasion as well as important molecular group. So this is the gross specimen of hysterectomy specimen of uterus in which there is thickening of endometrium which is filling whole cavity of endometrium. So here we can also appreciate abnormal growth which is present in the endometrial cavity. And here in this both the cut surface, cervix looking free. So whenever we see grossing of these malignant specimen, hysterectomy specimen, we have to look for uterine cavity which shows either mass or growth projecting into cavity, or sometimes there is diffuse thickening may be present, and it is indicating tumor presence and extent within cavity. Tumor surface generally exophytic, soft and may be friable or necrotic, most common in endometrial type carcinoma. Cut surface homogeneous tan grain, low-grade tumor, heterogeneous with hemorrhage and necrosis in high-grade lesion. It reflects tumor grade and active tumor. Special features include flaky appearance in tumors with squamous differentiation and gelatinous or colloid in mucinous differentiation. It suggests histologic variant. Now, tumor size, we have to measure in 3 dimensions in centimeter, which is required for staging and correlation with invasion depth. Specimen orientation mark anterior and posterior wall before sectioning because it requires for precise mapping of invasion sites. Now for myometrial invasion, we have to cut perpendicular to anterior and posterior walls and identify deepest point of invasion, which is crucial for FIGO staging. Depth of invasion recorded in millimeter and as percentage of myometrial thickness, because less than 50% myometrial involvement or invasion, it is included into stage 1A, and if it is more than or equal to 50%, then it is stage 1B. Adenomyosis. Tumor may extend into adenomyotic foci, so it is important to differentiate adenomyotic foci, which may mimic deep invasion. Lower uterine segment involvement, in which if tumor extends near cervix, then take sagittal section so that we can see tumor, lower uterine segment and cervix in a single section. It is needed for stage 2 evaluation. Normal endometrium or uninvolved endometrium, we have to take the section from adjacent normal endometrium, which provides baseline for comparison. Now, cervix, adnexa and spiroxa sample, even if not grossly involved, because sometimes microscopic spread can be detected from this area. Lymphovascular invasion generally not visible, but sometimes if tumor emboli in vascular space is visible, then we can it indicates aggressive behavior. Associated findings include polyp, hyperplasia, myomas, adenomyosis, or any other lesion which may explain abnormal uterine bleeding or coexist with carcinoma. What are the number of blocks required? So, for adequate sampling, 1 block per centimeter of tumor, which include deep invasion and interface, so it ensures complete evaluation. So this is how we can gross the whole specimen if we are receiving of hysterectomy specimen. But suppose we are receiving biopsy. So what are the important issues in endometrial biopsy interpretation? So key questions are whether it is benign versus malignant. If malignant, what is the grade, what is the histologic subtype, and whether arising from endometrium, going to endocervix, or arising from endocervix and reaching to endometrium. And the challenges include atypical hyperplasia or EIN versus well-differentiated endometrial carcinoma. Avoid overcalling benign mimics, which is tissue artifacts, pregnancy-related changes, metaplastic cytoplasmic changes, and in biopsy, invasion rarely seen, so rely on architectural criteria. So, what are the criteria for well-differentiated endometrial carcinoma? So, diagnosis require morphologic evidence of stromal invasion and 3 key features. Any one is equal to carcinoma. So, feature include confluent or cribriform gland, irregular infiltrative glands plus desmoplasia, extensive papillary pattern. And this stromal invasion criteria as well as these all 3 features of endometrial carcinoma we are going to discuss in next video. So if yet you haven't subscribed the channel, please subscribe this channel so that you can easily understand what are the different criteria for myometrial and stromal invasion, as well as what are the key features, how to measure the invasion, what are the key features that you will consider when you go for endometrial carcinoma diagnosis. So, confluent cribriform glands, which is merging glands with no intervening stroma, irregular glands with desmoplasia, in which FZ gland arrangement with fibroblastic stromal reaction, and extensive papillary pattern, which is complex papillae beyond benign metaplasia. So, in detail, we are going to discuss in next video. Now, what is quantitative guideline? Diagnostic area should involve more than or equal to half of a 4x field. Means scanner view, if we are observing, then the malignancy portion must include more than or equal to half of this field. Total field of this 4x field is about 4.5 mm field. Around 2 mm field must have this tumor portion. Now, what is the purpose? It is to avoid tangential cuts and artifacts. Always be cautious in scan biopsy for the diagnosis and to apply this criteria. And suppose in biopsy, even you have less than half high power scanner view, but invasive pattern is clear, then go for the diagnosis. Now, what are the pitfalls? Atypical hyperplasia EIN, repair changes, polyp with gland crowding, area stellar reaction in pregnancy, and artifactual gland crowding. So, lastly, some practical points we have to keep in mind, that always go for stromal invasion, which is a cornerstone for the diagnosis. Second thing, look for stromal reaction, means desmoplasia, cribriform growth, papillary proliferation, and in scanned biopsy, be conservative and correlate with clinical and imaging data. Now, in next topic, we are going to learn how to measure myometrial invasion and different criteria for diagnosis of well-differentiated endometrial carcinoma. So, if you found this video helpful, please like, share and subscribe this channel for more such type of videos. So, thank you very much and stay tuned.